Good evening, everyone, and welcome to the Colorectal Surgery Virtual Education Series. It is my great pleasure to introduce our speaker tonight, Dr. Michael Valente. Dr. Valente is a colorectal surgeon at the Cleveland Clinic and serves as the program director of the Colorectal Surgery Residency Program. A Cleveland native, he completed his undergraduate studies in biology at the Gannon University, earned his medical degree from the Ohio University, and completed his general surgery residency at Summa Health System in Akron, Ohio, and then went to complete his colorectal fellowship at Grand Medical Center, The Ohio State University. Since joining the Cleveland Clinic, Dr. Valente established himself as an outstanding clinician, educator, researcher, and a leader in colorectal surgery. He has been deeply involved in residence and fellow education, has held leadership roles in regional and national surgical societies, and has contributed extensively to the colorectal surgery literature. Tonight, Dr. Valente will be speaking on anorectal anatomy, one of the most fundamental topics in colorectal surgery and the foundation for understanding many of the conditions and procedures we encounter in daily practice. We are truly grateful for his time and honored to have the opportunity to learn from his expertise and experience. Please join me and everyone in the committee in giving a warm welcome to Dr. Michael Valente. Thank you, Doctor.
Thank you very, very much for the outstanding introduction. I hope my mom will be watching this later to see how great I'm doing. But thank you so much. As you said, one of the most important and fundamental things that we do is learn the anatomy and understand the physiology and what sets us apart from other surgeons is our specialty of colorectal is just a little bit, just this piece right here, these last 8 to 10 centimeters. So we're going to go over some of that today. And if there's any questions, of course, please let me know. We could stop and go over things as much as needed. Some of it, of course, is a lot of it is anatomy and some physiology. So a lot of it is some definitions and whatnot. So please stay awake. But it should be a great talk. We'll get some clinical integration as well. So it's nice to know the anatomy, but what does it mean actually? So let me share my screen here and we'll get started. So once again, Michael Valente from the Cleveland Clinic, and I give part of this lecture to the fellows each year, at least in multiple different ways. So I won't read word for word, but the student's understanding of anatomy is so important, as I talked about. So how things work, the relationship to each other, and then clinical reasoning is what we're here for. So why should I be a master at the anatomy? Well, for what we're going to talk about today, so the TME, the total mesorectal excision plane, complex rectal surgery, transanal surgery, we're going to need to understand how to do it. Vast majority of what we do as colorectal surgeons is anorectal care. So benign diseases, fistula, fissures, hemorrhoids, presacral masses, IBD, perianal Crohn's disease. When you're making a J pouch for ulcerative colitis, understanding what the anal transitional zone is and knowing how to make a coloanal or ileoanal anastomosis. Pelvic floor diseases, integral part of what we do as well. And all of this is integrated with the physiology of normal defecation, the physiology of how we move our pelvic floor, how we move our bowels. So we'll talk about that today. So like I said, it distinguishes you from general or other surgeons because this is something that we spend 1 to 2 years or more really understanding these last 8 to 12 centimeters of the GI tract. So I ask my fellows every year, first lecture is how long is your right digit, your index finger. So your index finger on your right hand, if apparently if you're going to be doing, or if you're right-handed, you do a rectal exam with your right hand. It's one of the most important tools that we have as a colorectal and general surgeon, but especially as a colorectal surgeon. So I make them measure it, how long from the tip of the finger to the PIP joint, how much from the tip of your finger to your cuticle, so my finger is 8.2 centimeters long. The PIP is about 4.5 centimeters, so to the cuticle is 1 centimeter. So these are things that I get a ruler out every year and I make the fellows and the residents measure their finger. It's critically important to understand when you're doing rectal cancer care and you're trying to see the distance or you're trying to figure out, that's the anal rectal ring, where is the tumor? And we're going to talk about those things today. So make sure you get your measuring device out, measure your finger. I know it sounds crazy, but this is what I had to do when I was a fellow, and it's one of the most important things you're going to do. So many of you are ending your fellowship in about 2 months, and many of you maybe finished your fellowship already. And when you look at this picture, you should be able to name all these things like that. Like this is critically important. This is where we live. I know it's great to do, robotic TME surgery and all these fancy things, but this picture right here is what sets us apart. And understanding and how it works and when it doesn't work and why it doesn't work and how do we fix it. That's why we're here today. So I'm not gonna ask. Usually I'll ask the fellows that come up and we'll go through each one, but. So you're looking at the longitudinal muscle, the circular muscle, valves of Houston, Mergagni, the internal, external sphincters. So these are some things that at this level, even through 5 to 7 years of general surgery, we kind of go over this a little bit. But as you finish your fellowship or as you're going into fellowship, you need to know this. This is the basic stuff. So we're going to go more detailed today about what each thing is and what it does. This actually comes from the AJCC. There's a couple of different sources that I really want to make sure that all the fellows understand is the Joint Commission on Cancer, the NCCN guidelines. These are things for all colorectal surgery, but I get a lot of good pictures and a lot of good anatomy from the Joint Commission on Cancer updates. I believe this is from the eighth or ninth edition, the ninth edition here, I believe. But nonetheless, this gives you like an overview of the anal rectal region, and we're going to talk about these levels. And you can see they go not just on the gross anatomical level of okay, the internal external sphincter. They're going over the internal, intercircular muscle, longitudinal muscle of the musculus propria. We're talking about histology, microanatomy as well. So critically important to understand your histology because you have to understand your histopathology. So we're going to go over some histology again today. So some gross anatomy and microanatomy and physiology. So I know it's maybe a little boring to go over these things, but critically important to understand what these definitions are. So the actual anus begins at the anal rectal ring and ends at the anal verge. That's great. And sometimes people, what's the anal rectal ring? What do we? Some people call it different things, but it's so this is what we call the surgical anal canal. What the anal rectal ring is, and I'll show you on the picture again, is we'll refer back to the picture numerous times, but that's where the rectum uh, it becomes the anus. And this is what you can feel on DRE. Usually it's that long circular strength, that long band. How high is that? It's a little bit different on everyone, but as we'll see, it's about 4 to 5 centimeters or so. So this anorectal ring is a fusion of muscular components of the internal sphincter, the external, especially the deep, and the puborectalis. So from that ring, that's where the anus begins, all the way down to the anal verge. The anal verge is where as I tell patients, or I tell sometimes when they're learning anatomy, it's where the inside meets the outside world. It's that distal piece of the GI tract. So this is where we go from true anal canal into what we call the perianal skin. And we'll go over all these pictures again. It's a lot of information, but hopefully, when you watch the video here, you'll be able to read this at a slower pace and really understand it. So these are things I didn't really understand at all. These columns are Mergagni. Mergagni was Italian pathologist, anatomist. There's these longitudinal ridges of the mucous membrane of the anal canal, extend downward from the bottom of the rectum to the dentate, also known as the pectinate line, which this is like the big transition from the upper going from embryologically now, so endoderm derived tissue, so the upper rectum going into the lower portions of the anal canal, which is ectodermal derived. So that's, everything distal to the dentate line is ectoderm. You think of neurological pain, you can feel those things. When it's above that, it's endodermal. You don't feel those. It's a different innervation, correct? We'll go over that as well. So each of these columns over Mergagni has a small branch of the rectal artery, which also these columns make part of the hemorrhoidal cushions, otherwise known as just the hemorrhoids. And you can see this is these areas here, and we all know the dentate line or the pectinate line. And you see these columns right. Can you see my arrow, guys? Is that okay? Yeah. So you see these columns right here. These are what we call these columns over Mergagni. Clinical significance, maybe, this is where we have transition, essentially the dentate line. So you see them, maybe don't think about it too much during an operation, but maybe next time you'll take a good look at it. And here's Mergagni. He's from Padua, Italia, northeastern Italy, kind of close to where my mother grew up. I've been to the University of Padua where he had his theater. It's pretty interesting if you ever get a chance to go there. Uh, that's the only Italian anatomy I'll have today. There's a lot of them, but that's the only one I'll talk about today. So what about this transition zone, this anal transition zone? We'll talk about it on a couple different levels today, but just from an anatomical standpoint and histological standpoint. It's a distinct region in the anal canal where this epithelium comes from a columnar of the colon. to a stratified squamous, non-keratinized epithelium. So this zone, this transitional zone from colonic mucosa into rectal, colorectal into anal, and this transitional zone. Uh, is between the anal rectal ring to the dentate. And it'll make more sense when I show you the picture again, because I flew by it in the first picture. So now I'm just trying to see how much you know. So the anal rectal ring to the dentate, it's about halfway through the anal canal. That is the transitional zone. And what's in there? A lot of different cell types. They're transitioning. A lot of cell turnover, a lot of stem cells. This is where a lot of anal cancer happens. This is where HPV kind of does some damage in this zone here and gets its double-stranded DNA into our cells, and this is where all these kind of anal cancers will come from. They're all different cells, but as you know, we'll call them all squamous, essentially squamous cell carcinoma. They're all a little bit different, but they're all treated the same with modified Negro protocol. So what does transitional zone? It's a barrier function. There's a protection, sensory motor control. We'll talk about the sampling reflex later on. When we talk about some manometry. As I said, HPV susceptibility, preservation of the ATZ when you're making like a J pouch or a coloanal. When you have an intact ACD, you actually have better outcomes functional wise. And as we talk about people with an impaired ATZ will have a impaired sampling reflex when it comes time for defecation, and they have a difficulty. This is where low anterior resection syndrome comes in. Discrimination between liquid, solid, and gaseous material. This gets altered if your anal transitional zone is affected during an operation. So here's a nice view to go over some of the things we just talked about. So we see here we have the rectum with this columnar epithelium, and here we have this what we call the anal rectal ring. The anal rectal ring is right where this levator muscle, pubic rectalis, if you will, levator ani muscle comes in right around here. So this is the top of the anal canal, and it goes all the way down here to the anal verge. I'm sorry, this picture's got a little cut off, but all the way down to the anal verge. So from the anal rectal ring to the dentate line is that transitional zone. This is that area right here we just discussed. This is where a lot of that cell turnover takes place. Oops, excuse me. I'll go backwards one. And then I didn't go over it yet, but from this dentate line to the anal verge will be this stratified squamous non-keratinized. This is what we're going to call anoderm. Okay, so this is all a lot of information, but this whole unit is the anal canal or the surgical anal canal from the anal rectal ring to the anal verge, surgical anal canal. From the anal rectal ring to the dentate is the transitional zone. And then from the dentate down to the anal verge is anoderm, but it's all the anal canal. And we'll talk about anoderm next. So, let's go back here. So, dentate line or pectinate line. It contains anal glands, about 8 to 12. They secrete mucus secretions to help lubricate the anal canal when we have bowel function. This is where we get cryptoglandular abscesses. Okay, so this is the anal crypt. The anal gland drains into the anal crypt into the dentate line area into the anal canal. So this is where we get cryptoglandular infections. And as I said before, the dentate delineation between the endo and the ectoderm, embryologically speaking, different innervation we'll talk about the nervous supply, and which we'll talk about from an embryological standpoint. So what was that anoderm? So the anoderm is the stratified squamous non-keratinized epithelium between the dentate line and the perianal skin. That's it going from essentially the dentate line to the anal verge. Specialized epithelial lining of the lower anal canal, highly sensitive, hairless, gland-free, crucial for sensory defecation. So when we talk about anoderm, one of the clinical scenarios that we talk about anoderm is when we do a hemorrhoidectomy. So when you're doing a hemorrhoidectomy, everyone's going to say, if you're going to do a 3-quadrant hemorrhoidectomy, you must be very careful that you don't take out too much anoderm. What happens if you take out too much anoderm? You get a really bad cicatrix, you get a bad anal stenosis, and then they got to maybe have dilations or anoplasties, etc. So what is this anoderm? What are we even talking? I didn't know what they were even talking about when I was in residency. Anoderm, it all looked the same to me. Even in the beginning of fellowship, it all just looked the same. Like, okay, well, I know the dentate line. But what does it mean to leave this? Really, from the dentate to the anal verge is anoderm. There's no hair there. It's kind of shiny when you pull on it or stretch it. That's the column of tissue between your hemorrhoid closures, if you're doing like a Ferguson closed technique, or even a Ferguson an open technique. If you're going to have your incisions, you have to have, we say a centimeter, but 1 to 2 centimeters, 1 centimeter between your hemorrhoidal excisional areas. You have to have enough anoderm healthy left behind at the end of the procedure where there's not going to be some really bad stricture. So what does that mean? A lot of times, maybe only a two-quadrant hemorrhoidectomy we performed in a lot of patients. If and maybe there are smaller areas, you could just band them or ligate them, et cetera. But so this is what we talk about anoderm from a clinical standpoint. Why it's important. You don't want to. You have to leave enough behind so you don't have anal stenosis. So after the anoderm, so that's stratified squamous, non-keratinized, no glands, no hair. Okay. So then after that, at the anal verge, now we have the perianal skin, formerly called the anal margin. We don't call it that anymore. It's called perianal skin, and this is stratified squamous keratinized. So there's hair, there's glands. This approximately is from the anal verge to about 5 centimeters. So once again, now we have the anal rectal ring to the anal verge. That is the surgical anal canal. That is intraanal. Those are where anal cancers, about 80% of anal cancers occur. And then if you have perianal skin, that is from 0 to 5 centimeters from the anal verge. That would be perianal skin anal cancer. Also anal cancer, but it's on the outside. Both treated for the most part with modified Niagara protocol, combined modality treatment with chemotherapy and radiation, 5-FU, mitomycin, and 54 to 65 gray of radiation. Anything outside of 5 centimeters is skin cancer, buttock cancer. Okay, so we're talking anus, canal, perianal skin, and then anything outside 5 centimeters is. Let me go back to the. I know, sorry, but this is that picture right here. So anal canal, anal rectal ring to the anal verge. There's the anoderm. Here's perianal skin, number D, letter D here. This is between 0 and 5 centimeters. And anything outside of that would be just a skin cancer or skin lesion. Sorry. Whew, maybe you gotta take a break, huh? I'm joking. So, I'm just, any questions yet? I'm sorry. Good. All right. Very good. So I'll keep trying to go back to pictures as much as possible because you don't want to hear me just talking. But hopefully, when you watch this on video, you'll slow me down and you'll look at the pictures. And but these are all the things that I teach my fellows beginning the first lecture, the second lecture, maybe the third lecture of the year is multiple lectures like this going over what they need to know. And hopefully, if you're at the end of your fellowship in the next 2 months here and you're listening to me talk about this, this will be your cue to make sure you read about these things because this will be on your boards. But more importantly, this is, to serve patients and your career going forward. So the external anal sphincter, traditionally divided into three different parts: deep, superficial, and subcutaneous. This is voluntary. It's striated. We have control. This is our squeeze pressure, and this is mediated by the pudendal nerve. And we're going to talk about nerves today because they're super important. This is S2 through S4. This is from the sacroforamina, and this is um, deep part. It blends with the puborectalis muscle. Um, and part of this actually joins the superficial transverse perineal muscle, which makes the perineal body, which we'll talk about later in the pelvic floor. There's a superficial part. This inserts direct into the perineal body and to the coccyx and anal coccygeal ligament, and the subcutaneous part lies beneath the skin, encircling the anal verge. Excuse me. Go back there. So we have the deep, the superficial, and the subcutaneous portions. No, anatomically, in the operating room, I'll be honest, I don't see it like that at all. It's not something that, it's something that now, only time this really is important. Well, it's very important when we're talking about transsphincteric fistula and ano, and there's a little bit section on fistula. I know Dr. Hall talked about fistula not too long ago, and she's a master at it, and I learned a lot from her when she was at the Cleveland Clinic as well. Um, but when you talk about how much external sphincter muscle is encompassed by this fistula and ano, you're talking about thirds they call it, so 1/3, 2/3, the whole thing. So there are certain complex high, mid, or low transsphincteric fistula and ano. When it's low, it's subcutaneous, superficial would be mid, and deep would be high. Highs are the worst. So we're not going to talk about those today, but that's when that comes into role in terms of clinical understanding. But you don't really see the differences while you're in the operating room. So internal anal sphincter, a bit different. This is a continuation of the muscularis propria, the inner circular smooth muscle layer of the muscularis propria, that third layer of the bowel wall, the muscularis propria. The first section is the inner circular smooth muscle. That is what the internal anal sphincter actually is, a continuation of that. This is about 70% of our resting tone. It is contracted at rest. It is always contracted until we tell it to relax, and we'll talk about that a little bit. The rest of our continence is from some external sphincter muscle, but also from hemorrhoidal tissue and the cushions, the hemorrhoidal cushion. So a lot of our continence is actually from our hemorrhoids. So that's why, overzealous hemorrhoidectomy can also result in some continence issues. The internal is innervated by autonomic, sympathetic via the hypogastric, and we're going to talk about the hypogastric plexus today for contraction. And the parasympathetic, you'll learn about when we talk about the act of defecation. We're going to have parasympathetic involvement for the muscle to then relax. So up close picture early on. So we have the external sphincter. There's peritoneal reflection. Here's the external, the pubo rectalis essentially coming down, and then external sphincter muscle right here. We have the internal sphincter muscle right here. This is the continuation of the inner circular muscle you see right here, coming down internal sphincter muscle. Dentate line, we have the anal gland, the crypt leading into secretions, and this is where cryptoglandular abscess occurs. And then you got this arrow right here. It looks like a combination of some external fibers, maybe some internal fibers, and it looks like it's what I would consider the intersphincteric space. And that it is kind of what it is. But it's something that you don't really appreciate it too much. You see it in the pictures, but this conjoined longitudinal muscle. So what is it? It's located between the internal and external anal sphincters. It's a continuation of the outer longitudinal muscle of the rectum. So that's outer longitudinal is skeletal, and it passes as it passes through the anal canal. So also it combines up with the internal sphincter, making a submucosal muscle layer actually, and extends in through the external sphincter. What it does, and it goes all the way down, and it goes right to the anal skin, and it kind of the muscle fibers go out and pucker in. That's the corrugator cutis ani. That's where we get that puckered skin look of the anal canal. Let's go back to it there. So we have, puborectalis, levator, external sphincter, internal sphincter, the corrugated longitudinal muscle right here, and then it gives rise to this corrugator ani muscles right here. So what does it do? When it contracts, it shortens and widens the anal cal. It actually helps with flatten the hemorrhoids and during defecation, essentially. Works with the internal sphincter to open the anal canal and facilitate stool. It supports the vaginal and pelvic floor muscles as well. And this is an area where anorectal sepsis will spread through pathways, and it will go into multiple abscess fistula directions. It could go suprasphincteric, it could go transsphincteric. So this is a pathway for infection during fistula surgery. And then this essentially what it is, I don't even realize it when you're doing it. You just think, oh, it's an intersphincteric space. But this muscle, these fibers is what makes this space. And you're kind of essentially bovening or cutting, kind of spreading in that plane. Okay. Big look over once again of what we did. I'm just going to say a few things. Colorectum here. The levator ani muscle made up of these guys is the top of the anal canal, otherwise known as the anal rectal ring. The anal rectal ring to the anal verge. 4 to 6 centimeters in length, about 5 to 6 in the male, 4 to 5 in the female. That is the surgical anal canal, anal rectal ring to the anal verge. From the anal rectal ring to the dentate line is the transitional zone. From the dentate line to the anal verge is the anoderm, okay? And then from the anoderm outward, or the anal verge, the anal verge outward is perianal skin. We got internal muscle, external muscle, conjoined longitudinal muscle, corrugator cutis ani, pallidum mergagni. Valves of Houston are use first, second, third valve. Clinical relevance of that is you kind of know where you're at. If you're at the second valve, that's sort of doesn't look like on this picture, but it's the anterior peritoneal reflection, or the intraperitoneal portion of the rectum. That's important for transanal surgery, but that's not, foolproof. What do the valves do? They help, I think, accommodate essentially stool storage and then passage. They're not any other mammal on Earth, just in humans. And they're picked up and described by Houston out of the Royal College of Scotland in the 1800s. Same picture. This one has the embryological, columnar, transitional, squamous non-keratinized, and then squamous keratinized. It was just another view with the vascular anatomy, and this is showing the vast majority of the anus is by the inferior rectal artery, but the middle and the superior also contribute to the upper anal canal and the lower rectum as well. So here you see sort of that arterial distribution. Are we still good? Okay, guys? Perfect. Okay, so we're going to go from the gross anatomy section, do a little bit into the microanatomy or histology. I'll be honest, I loved histology in medical school. I thought it was fantastic. We had to look under microscopes. Like we actually had I'm not that old, but I was talking before. I'm like I live old, I think. I'm old school. I do a lot of open surgery, but like I was in that generation where I learned how to type on a typewriter, but I also, can do power, so it's a very strange. I lived in this strange. We had to actually use microscopes. It was great. So I feel bad for some people. We had to actually focus. Now you guys get it all for free. I'm joking. So the general GI tract, mucosa, submucosa, muscularis propria, serosa, or adventitia. Key points of the mucosa: epithelium, lamina propria, muscularis mucosa. There's a basement membrane mixed in there. I'll tell you that in a minute. The submucosa, important. This is where things go into here. We got cancer. We got Meissner's submucosal plexus. We'll talk about that briefly. And the muscularis propria, the thick layer, the circular, intercircular. And then in between those is the myenteric plexus of Auerbach. And we'll talk about that today because that's going to be important for the role in defecation and the sensory function of the colorectum and the anus. And it's mediated through the enteric nervous system, the act of defecation, and the outer circular longitudinal muscle. And then we have serosa or adventitia, depending on where our organ is and what we're talking about. Just a brief histological. When I took our boards, there was a picture section on the boards, on the written boards, where we would have pathological disease or entities with a histological diagnosis, and you would have to pick up. This is microscopic colitis because there's a bunch of macrophages in the lamina propria. So I don't think they make you do that anymore. But here you see the mucosa, the submucosa. Once it breaks through here, it gets into becoming cancer. And with submucosa, you have S1, S2, S3 for transanal surgery. You got the muscularis propria, intercircular, outer longitudinal. In between those is where you would see Auerbach's plexus. A Meissner's plexus would be somewhere in here. Those are blood vessels, actually, excuse me. And then a serosa or adventitia. Once again, the epithelium of the colorectum and somewhat the anus as well is mostly of these large glands which secrete which have goblet cells which secrete mucus, and they absorb mostly a lot of water in the colon and the rectum. So the mucosa, innermost layer encases the lumen, three layers: epithelium, lamina propria, and the muscularis mucosa. Well, this is just a big kind of overview. Simple columnar, has long microvilli that helps aid in movement of feces. Crypts of lubric, remember these lubricun, and goblet cells. These crypts is where absorption takes place. Much different than the small intestines. The colon has these goblet cells, which secretes a ton of mucus, as we know, and a lot of immune cells. Submucosa, loose connective tissue, and important things here: blood vessels, nerves. This is where we get, perineural invasion, perivascular invasion, and this is where things can also get into the lymphatics. Submucosal, Meissner's enteric nervous plexi, and we'll talk about that a little bit later. So the muscularis propria, we talked about a little bit from the gross anatomy, intercircular and outer longitudinal. Inner layer is the myenteric plexus, between an inner and outer myenteric plexus. This is where peristalsis will occur as well. Oh, this is of course the longitudinal layer is when they are in the colon. This is you'll see them as that's the Taenia coli. There's three Taenia coli located, on the mesenteric side and the free side, or on the mental side onto the transverse, and that is the outer uh, outer longitudinal. That's skeletal muscle. And as we know, when we get to the rectum, as we're talking about today, that's where the tennae convalesce together to kind of make more of a broad, generalized thickness instead of having three distinct bands. That usually occurs around the area of the sacral promontory, just from a kind of intraoperative landmark perspective. Serosa covers all intraperitoneal structures as continue with the parietal peritoneum. So the parietal peritoneum is the underlaying of the abdominal wall, the retroperitoneum, etc. And visceral peritoneum covers all of the viscera. So the serosa is thin, double wall, simple squamous epithelium. This will be our cecum or transverse or sigmoid, the upper part of rectum, the free areas. This is serosa. Now the adventitia covers retroperitoneal structures made up of connective tissues. So this is the lower rectum, the anus, and the ascending and descending colon that are fixed. We have to, mobilize them at the white line of Tolt. That is going through the adventitia. Both contain blood vessels, nerves, and lymphatics. Okay, 2-second break. Any questions so far? Mhm.
There's one question in the chat, but we can leave it till the end. It's okay.
No worries. That's cool. No worries at all. Okay, 7:30. Good. So pelvic floor. So as you make your way through fellowship, understanding of the pelvic, people like, oh, I'm not going to do pelvic floor. I'm gonna be a cancer surgeon. I'm going to do, J pouches, whatever. Pelvic floor is an integral part of all that we do. It's a pillar of colorectal surgery and anal rectal surgery. It's critically important to understand. You're going to have patients who may have. I have this a lot of times where we have a patient who had maybe a hemorrhoid surgery and now they end up with a pelvic floor dysfunction. We'll talk about some anometry things here in a little bit, but maybe they had some trauma or insult going on, and now, maybe they just it was just as a surgical issue. So a lot of these patients were having normal kind of life. They had some sort of surgical problem or some sort of insult, and now they have pelvic floor dysfunction. So critical, understand it, and we'll learn about it a little bit here today. Pelvic floor is this muscular sheet that your entire the viscera pass through, and we'll show some images. Essentially, these muscles are supporting the structures of the pelvis. So the pubococcygeus, puborectalis, iliococcygeus, ischiococcygis. Primarily somatic innervation, pudendal nerve again, S3, S4, also autonomic fibers. Here we have this. We showed this picture before, but essentially this is just showing levator ani, puborectalis, from the tip of the coccyx, essentially coming all the way around, all pelvic viscera, essentially going to essentially the pubic symphysis is this band of tissue. We'll talk about some of the muscles, the perineal body, as we talked about. It's between the urogenital and the anal canal, the urogenital and the gastrointestinal. Superficial and deep transverse perineal muscles, as we talked about, is an extension of the external sphincter and also the bulbar spongiosus in the male and female. Supports the pelvic organs, so it helps kind of maintain the pelvic floor, the bladder, uterus, and the rectum. It's a great surgical landmark as well. The perineal floor strength, it provides resistance during pressure, during coughing, lifting, childbirth, and it contributes to continence as well, sexual function, urinary function, and sphincter mechanisms. Here's a view of the female pelvic floor. We have the vagina, the perineal body, the bulbar spongiosus, as we talked about. This is where you would potentially make a Martius flap as for complex fistular perineum. Maybe Dr. Hull talked about that last time. This is where you would get your Martius flap. This is that superficial transverse perineal muscle. This kind of convalesces with the external sphincter here, as we talked about, and then they all kind of insert here to this perineal body. perineal body strength, size, shape change throughout lifetimes. As you're younger, during older, it gets a little bit weaker. Of course, as we get older, as pelvic floor laxity and all the muscles tend to get a little bit less, will get weaker. And here we have the pelvic floor musculature showing connection in anococcygeal ligament. Once again, we'll talk about this in a few minutes in relationship to how we do an abdominal perineal resection and what we're going through and our landmarks for that. Here's a generic view of this pelvic, but I like it because it shows this sheet as a kind of a sheet of one big muscle and connective tissue that supports all of the pelvic organs here. This is when we talk about defecation and the anorectal angle. So this is essentially the anorectal angles being caused by the puborectalis, as we see the coccyx attached to the anococcygeal ligament here, wraps all the way around the anorectal junction to the pubic symphysis or pubic ischiotubers, or these pubic bones here. And we're keeping at an 80-degree angle at normal rest. As we go through the active defecation, we'll have contraction of these muscles and this angle will open up. And we see here now during straining, the rectum goes from this view to here, where we have descent of the pelvic floor, relaxation of the puborectalis, relaxation of the internal sphincter muscle, contraction of the external sphincter muscle to allow defecation and the angle to open up. If you have a dysfunctional pelvic floor, or dysynergia or paradoxical contraction of the puborectalis, when you strain or have the urge to defecate, instead of the anorectal angle opening up, becoming less acute, it's going to actually get tighter. So you're trying to defecate against a closed angle, essentially an obstructive defecation syndrome. So once again, when we're doing an APR, this is sort of your landmarks when you're doing dissection. You have to go to the tip of your coccyx, essentially to the ischiotuberosities laterally, and to the perineal body. In a male, we'll see next, it's a little bit more difficult, I think, with the prostate and the urethra. But here in the female, we have the vaginal wall extremely close as well. So we're going through the perineal body, going through the levator ani muscle, going through that when we do a nice cylindrical APR in the fashion of extra levator or Miles technique, where you're actually taking the levator muscles. This is kind of the zone that you're going into. For a male, it's very similar, but we have a little bit different anatomy here. Perineal body, important, of course, but the bundle spongiosis a little bit larger and a little bit different. But this is the male anatomy, very similar. But as I was saying, you have the urethra coming right through here, right in this zone. So you got to be critically careful anteriorly during an abdominal perineal resection during the perineal phase. This is a critical area. And in the female, we're taking it off the vagina. In the male, we're taking it off the prostate. But if you stay in these correct planes, knowing this anatomy will help with that. And I recommend if anyone in your institutions does APRs in the prone position as well as the lithotomy position, please take a look and try to get into those operations where you could try this operation in the prone. It's a much different view, and once you see it in lithotomy all these years and you go prone, you kind of have a better appreciation, a little bit different. And certain patients, certain body habitus, certain areas going prone. I used to do almost all of them prone, but I've been a little more selective lately, just because it's a bit of a hassle to make the turn during the operation. You have to make the colostomy and flip them over. But imagine this just flipped up. It's a good way to better understand the anatomy. Only thing I'll highlight here is you see the pudendal nerve coming here. This is the pudendal nerve coming through the pudendal canal or Alcock's canal. When you're doing your local anesthetic for perianal surgery, generally speaking, you're going to hit the inferior rectal nerve coming off the pudendal. You're going to do your injection here, 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 kind of a 1, 2, 3 on both sides usually. And then some folks kind of go into the intersphincteric space depending on what you're going to be doing, and then many folks will go and aim towards the pudendal nerve. Now, the traditional pudendal nerve block is, you would put your finger in the anal canal and you feel, and you're going right into Alcock's canal, etc. But not many people actually do a true pudendal nerve block for colorectal surgery or anorectal surgery, but it is something that you should be aware of. I'm not going to highlight too much of this. Essentially, yeah, we're gonna you guys should know most of this. There's not too much I want to add. The superior middle rectal veins drain into the IMV, then the portal system. So the inferior rectal vein goes into the iliacs, then to the cava. So this is where, and the lymph nodes follow the same pattern. So the distal rectum anus, inferior mesenteric artery, internal iliac, and inguinal nodes. So we're talking about a distal distribution now. When you essentially things like dentate line and below, we're in a different embryological plane, different anatomy. We're not going into the hepatic portal system. Why, number one spread of cancer is the liver, followed by peritoneum, then the lung. When you look at low rectal anal, you're looking at inguinal, you're looking at lung, and sometimes brain, sometimes other systemic circulation may be more prevalent in the distal tumors. That's the main thing you should be aware of there. Okay. We're going to spend a little bit of time here, but then I don't want to give you too much, but the nerves. So the nerves are something that took me a long time to figure out. Even when you're doing an operation, you only see certain ones of them, or you should only see maybe certain ones of them sometimes. A lot of times you don't even know that there's nerves in that area, especially anteriorly, around Denonvier's fascia, et cetera. So we'll talk about the nerves here, which I think is critically important. The main players, we're going to be talking about the superior hypogastric plexus, the hypogastric nerves, the pelvic sphincteric nerves, and the inferior hypogastric plexus. These are some of the most important things we'll be talking about, in addition to the sympathetic trunk as well, which we'll see here. Just another view, and the superior hypogastric plexus is right at the area of the inferior mesenteric artery. So this is one area of damage to the superior hypogastric plexus. As it splays out over the iliacs, this is where you have the hypogastric nerves. The hypogastric nerves are the ones that we often see during the total mesorectal excisional plane, and we'll talk about those in a little bit. As those nerves continue downward and merge with the pelvic sacral nerves, they become the inferior hypogastric plexus. Those come into play during an anterior dissection, anterior by the prostate, by the bladder. So we'll talk about those as well. These are pictures that I show my fellows, and then I show them this at the beginning of the year. And actually, I think I might show them this at the end of the year too. To see how much they remember from the beginning of the year. But if you could take a look here, you should understand that we have aorta. I know that this is superior hypogastric plexus. This looks like a sympathetic nerves coming down as well. So let's take a look. So we got sympathetic trunk here. We got superior hypogastric plexus. This is under sympathetic control. So these are ones where if I ligate the IMA and I grab this nerve and they're kind of being pulled up and I ligate it there, that patient's sympathetic issues, he's going to have retrograde ejaculation. That's going to be his biggest side effect from that. So those are important things to talk about here, right? So we got sympathetic plexus coming down and they break into well, they don't show it here, but I'll show you. So I'll show you next one. But remember this from medical school, and you're like, oh my God, I'm never ever going to need to know any of this stuff ever again because this is just crazy stuff. You don't got to know the whole thing, but what I'm talking about today is essentially this bottom section. We got the, lumbar sphincteric nerves, hypogastric plexus, sacral plexus. Then we got the pelvic sphincteric nerves from S2, 3, and 4 on this side. So we got the autonomic nervous system, parasympathetics, sympathetics. Here we have the enteric nervous system when we talk about defecation. So there's a lot of stuff to talk about. So these are just written down for your use when you read this later on. I'm not going to go over this all here, but the superior hypogastric plexus, uh, sympathetic fibers near aortic bifurcation, sacropromontory, um, descends and divides into right and left branches that continue as the hypogastric nerves. These are the ones that you see that go down over the sacropromontory. So this is sympathetic innervation, continence, peristalsis, distal colon rectum, sexual function. So mostly ejaculation emission. That's those. Those as the continuation of the superior hypogastric plexus are these hypogastric nerves, paired right and left. They go all the way down, medial to the ureter. When you're mobilizing right over the sacral promontory, getting into the TME plane, this is where you can damage these. Once again, this will also have ejaculatory dysfunction. So this is the one that we mostly see, and I'll show you a picture of that. But what are these pelvic spleen? You ever heard these nervi erigentes? I didn't know what these were for like 20 years. So these are the pelvic, these are the parasympathetic side. So we had the sympathetic we just talked about, the hypogastrics. Now we have the parasympathetic. These are the pelvic splanchnics coming off of the sacrum, S2 through S4. Parasympathetic point. So this would have to do with erection. This is where we get into these problems. We may have erection problems. Um, and then this will come, they'll join up with the hypogastric nerves to make the inferior hypogastric plexus. This is the one that's around the prostate. So inferior hypogastric plexus, seminal vesicles, prostate, anteriorly in a male. These are the ones that get banged up and essentially destroyed during prostatectomy. You hear about those, or doing a radical cystoprostatectomy when you're doing a conduit, when you're doing an exoneration. These are the ones that cause impotence, essentially. So preserve these during TME, sharp dissection, holy plane, IMA root, presacral space, lateral stalks, and the anterior dissection are your zones of danger. Nerve sparing techniques, robotic surgeries obviously helped out quite a bit. Here's a view. We have cephalad, caudad here. So we have the superior hypogastric plexus here, left hypogastric nerve. This is where we're going to get into our TME plane right here. So when you're pulling up on that rectum and you make that kind of first cut into that holy plane or that areolar tissue, you can see that, there is these veins, come down and kind of they get tented up sometimes. So you got to like kind of push those down. You're keeping those down and staying above those. Here's a nice another view. So there you enter the TME plane. That's the holy plane. Look at those nerves right there. So you're going to be going in this direction now and keeping those down in lateral. Here's another nice view here of the superior hypogastric plexus. IMA would have been ligated up here. And then here we have the left and the right hypogastrics. These are the ones that you really see the most during your dissection. These will come down, convalesce with the splanchnic nerves, and then go anteriorly to then get injured during the anterior dissection, as we talked about. All right. Do I still have maybe 5 minutes to talk about physiology, or what do you think? Yeah, good. Everyone's still awake. Good, good. All right. So real quick, we learned the anatomy, the microanatomy. What about what's going on with the physiology? So in 5 minutes, let's do anorectal physiology. Uh, Physician with an in-depth knowledge of normal and abnormal physiology of the anus and the rectum can apply the results in a meaningful way to help diagnose and direct. Some of my most happy patients are the ones who've been to 3 or 4 different people with some kind of weird, maybe pelvic floor thing, or maybe some anatomy thing that maybe was a deep postanal space abscess that no one else picked up on. So when you have this, you could really, really help a lot of people. When we do manometry, resting, squeeze, strain, rare, rectal anal inhibitor reflex, we'll talk about that, and other things here, including sensation compliance and expulsion test. We talked about resting pressure is the internal anal sphincter, about 70%, greater than 40. When you see maximum resting pressure, that's the highest pressure in the anal canal. That's the high pressure zone. That's when they test where the highest pressure is. Squeeze pressure is mostly external. Normal is greater than 110. When you see someone, if you ever get like maybe a manometry because maybe they had a sphincterotomy and it failed, and their resting pressure is like 95, 100, and their squeeze pressure is like like 150. That person has a lot of muscle, and you could probably safely do a repeat sphincterotomy because probably there wasn't enough muscle cut the first time. So that's sometimes when I get that. So what is this rare? During a manometry, we this is elicited, we could see it, is a thing that happens normally as well. It's called the rectal anal inhibitor reflex. On manometry, it's a decrease in resting anal pressure in response to the balloon that's filled up. So the relaxation of the internal anal sphincter is a response to the distension of the rectum. We blow up a balloon. During normal life, stool will fill up the rectum to elicit this response, and we'll talk about this. But on manometry, resting pressure, we put a balloon in the rectum, we blow it up, and the sphincter relaxes. And the sphincter relaxes for a lot of different reasons, and then it's going to recover. So that is what the rectal anal inhibitory reflex is, and what we'll go over a little bit more. It's mediated by that myenteric plexus, that Auerbach plexus, mediated by the spinal cord. So stool goes into the rectum. There's a little bit of an increase, and then all of a sudden the internal sphincter relaxes. And when it relaxes, it facilitates some of that stool or gas or whatever it may be to go into the anus, into the transitional zone actually, to have sampling reflex. The sampling reflex allows the anal canal to discriminate between gas, liquid, and solid. An intact rear is dependent on an intact myenteric plexus. So people with Hirschsprung's disease, acquired by Chagas disease, Trypanosoma cruzi infection. So South America, Central America, even North America. So Hirschsprung's or Chagas, where there's a lack of Auerbach's plexus, will not have a rear. After a low anterior resection, a coloanal anastomosis or iliopouch anal anastomosis, you may also not have a rare on manometry because of the damage to the transitional zone. Hence, damage to the Auerbach's plexus in that region. So, rectal distension, there's a mass peristalsis, pushes fecal matter into the rectum, stretching the walls, mechanoreceptors, sampling mechanism, the stretch inhibits the rare. The brain decides whether to evacuate or delay, and if appropriate, we'll do an expulsion. We'll relax our pelvic floors. We'll increase our abdominal pressure to expel it. This is a nice little view. Rectal filling, rare. We we have an urge to defecate. The brain says we discriminate. Is this gas, liquid, or solid? Is it if it's gas, can I let gas out right now? Or is it really going to be gas? Oh, it's solid. I have to go to the bathroom. Is this a good place? Can I get to a bathroom on time? Okay, fine. I'm going to sit down, maybe use a squatty potty. You're going to put it in the right position. You voluntarily strain, you go to the bathroom. If it's not the right time, I'm going to contract my pelvic floor muscles and squeeze my muscles and hold it in. That's mediated by the sympathetic and the somatic system. That's the skeletal muscle. So here we are, rectal distension, going to the spinal cord, and it's a very complex procedure, but I don't want to go over too much. As I said, rare localized enteric reflex, myenteric plexus, independent of the central nervous system. You guys can read this later. I wanted to get you the most really in-depth of how this actually works, and I want you to read this later on. But this goes back to some kind of in-depth biochemistry as well. So signaling pathways, neurotransmitters, relaxation. The sampling reflex, as I talked about, there's areas in the zone of sampling in the anal canal, gas, liquid, or solid, and that your brain can distinguish that. When you have surgery on that area, that's why patients can't discriminate between gas, liquid, solid. Sometimes they think, you'll have patients say they can't trust their gas. They don't know what it's going to be. Their transitional zone, their anal canal has been operated on, or in some people with Crohn's disease or diabetes, they have lack of sensory awareness down there, and they have problems with discrimination. I think I'm going to pause because I can go on for like another hour, so I'm going to stop.
So we're gonna just have a look at the question section.
Yeah.
Someone has asked, have you ever seen disruption of the ATZ with PPH? The
Yeah, so that's a great question. PPH done the right way does really great for especially grade three circumferential hemorrhoids. That's one of the classic things that you'll hear about. I trained in PPH. I don't do any currently now. I have taken care of some really bad PPHs where the staple line was too distal. It was at the dentate line essentially or below. I've had some areas of staples kind of in that transitional zone in that anal canal, and you're too low. So the patient had chronic pain, stenosis. I don't know if they had much of a discrimination issue with that, but PPH can cause, if done in the right hands on the right patient, it's a very great instrument. But I'd be very careful if you're not really well versed in PPH procedure. Yeah.
And since we don't have any more questions, but
Yeah.
then since we're having the slide about spaces, I was anticipating, are we talking about the post-anal space and the pre-sacral?
Yeah.
We might as well just go
Yeah,
through.
you want to do it real quick? Yeah,
Yeah,
sure.
yeah, yeah.
Yeah, so this is yeah, that's good because these are important. So this one gets people not this one, but this one gets people. This one, the perianal perirectal spaces. So a lot of your landmarks are going to be the coccyx and this anococcygeal ligament. Um and so here you're going to have the superficial postanal space, that's between the buttock and the anal coccygeal ligament. But then this deep postanal space, this deep postanal space is bounded by the anal coccygeal ligament and the coccyx, the levator ani anteriorly, and it is an area that is classic for what we call a deep postanal space, which has the opportunity to turn into a horseshoe abscess. This is one of the classic missed areas because it's very deep, as it says, especially in a larger individual, where they may have vague symptoms really or deep kind of pelvic pain. And there's no external, sometimes no external findings whatsoever. There's no extension of the abscess because it's stuck inside this anal coccygeal ligament. It doesn't want to get out. Even when you operate on it, it's hard to get it out. So, and it has a chance to go all the way around um, and cause problems. We'll talk about that real quick. And then, so we have, like I said, the levator muscle above that, above supralevator space. And then this one right here between the sacrum and the rectum is going to be the retrorectal or pre-sacral space. The retrosacral space, I'll be honest, yeah. I gotta kind of refresh my memory of how I don't really see it like that. I think it's a continuation, but retrorectal space is where we're gonna have our presacral masses, and that retrorectal space can go kind of all the way down as well. We'll show some images. Um, Front view, we have your ischioanal space, your intersphincteric space, your supralevator space, and your subcutaneous or perianal space, I should say. And this is your classic areas. Now, any one of these can horseshoe, an ischioanal horseshoe, a perianal horseshoe, or intersphincteric. And then, of course, the deep one can. So the deep one tends to spread through and I'll show you a picture. Cats can't even. So here, oh, here we go. So here's the communication between those spaces that can all horseshoe any way you want. The peritoneum, intersphincteric, ischial, Just another one there. Another view. So, whoops. Okay, so here's another good view of this uh, anal-coccygeal ligament, the deep postanal space, and the supralevator space, and then the presacral space. All really kind of related to each other and in connection. This is why things can go. So here we have a sagittal view, excuse me, coronal view of here's a male, one of my patients actually, who had kind of vague pain. And you don't always see a CAT scan, but he went to the ER like 3 days of vague pain. And when they called me, like, hey, the resident was like, listen, it looks like a horseshoe. And I go, how's he doing? It's like, well, he's doing okay, but no white count, no fever, but he hasn't been able to urinate in over 20 hours. But I'm like, oh, he needs an operation. Like he's got sepsis, right? So these things can sit around for a very long time and are very difficult to get to. Here's the sagittal view, and here you see the tip of the coccyx, and here's the pus is right here in this deep postanal space. In order to, and you don't really see an anal coccygeal ligament here, but you have to break through that. So when you take this patient to the operating room, you we'll talk about the modified handling, but what you do in this operation, if you know that you have a deep postanal space on this based on imaging, based on examination, because there's no real external physical examination signs. There may be some erythema, there may be some, but sometimes they're very sick. So generally speaking, if I know it's there, I put them in the prone Kratsky position, jackknife, and you're gonna actually cut through the anal coccygeal ligament, and you're hopefully you're staying away from the external sphincter muscle, you're staying above it, or sometimes you have to even split and try to get. But a lot of times what I'll do is I'll take like a big syringe and a needle, and I'll kind of do as a guide and see where I'm going to cut down. And you cut down and you get into the space, and a lot of times that space, the deepest, it's very large. There's been pus in there. Sometimes it could be, you know 50, 60, 100 cc's of pus, really ugly stuff. And then you take a feel, and you feel like it's tracking all the way around, because there's a horseshoe extension. So that's the situation where, and this is a tough picture to understand, but the deep postanal space, here's your coccyx right here, here's your anus. You made the incision in, and then a lot of times, this is in the prone Kratzke, a lot of times you see this dotted line is where the horseshoe extension is. This is all pus, and pus goes all the way around in this component. They're all communicating with each other. So what you do is this is where you make your counter incisions. A lot of times you put a Kelly clamp, or even your finger, even a big Kelly, because you're going to go through, you're going to bovie on it. And this is where you put a Penrose, another Penrose. You make two counter incisions. Sometimes it's a horseshoe that's really long on one side and short on the other. Sometimes they're both long. Sometimes it's a unilateral horseshoe. Um, so you make counter incisions. Generally speaking, it's tough to do anything else. In the original Hanley procedure, he would kind of do a sphincterotomy and open up the internal opening. So these are all deep postanal space, all come from a posterior midline cryptoglandular process. So it's always a posterior midline anal gland and pit, or excuse me, crypt, that is causing the problem. So like anything else, you really just drain the sepsis the first time you're there, get them better, put drains in, and they're going to come back. Very often, if you could put a ceton in that posterior midline fistula tract, you'll come back for another day, take your drains, downsize your drains. Hopefully, that once you control the internal opening, your pus will stop draining out lateral. Then you could slowly but surely downsize the Penroses, the cetons, and it's a long process. But I didn't do I didn't talk much about the Hanley today, modified Hanley, but it's a great procedure. This is something where like, man, they had abscess. They missed something potentially, because it's just hard to find. It was a slow growing thing. All of a sudden, it rears its ugly head, and it's quite a disaster. But something to always have in the back of your mind. Oh, maybe this is a deep postanal space, and this is where CAT scans really do come in handy in the ER. Usually, we don't need that often, but for these, it comes in handy. Um, and I know Dr. Hall talked about fistulas, but the Parks classification, all the anatomy they learned about today. So obviously we have a intrasphincteric, we have a low or mid transsphincteric, suprasphincteric, extrasphincteric. So just some things to talk about there. That's all I got.
Thank you so much, Dr. Valente.
Yeah.
Really, the anorectal anatomy is really assumed to be straightforward, but really the level of details and clarity you brought today, really particularly around the pelvic floor, sorry, and the surgical planes, is quite relevant. So we're
Yep.
genuinely grateful. Thank you so much.
My pleasure. Thanks for having me, and good luck to everyone out there, and hope to see everyone around, and good luck. Thank you.
Pleasure ours. Thank you so
All right.
much. Bye.
Have a great night.
You too.